joint pain, morning stiffness, fever, fatigue. But is it lupus, RA, or vasculitis? In rheumatology, diagnosis is not always about symptoms, it's about solving a puzzle using the right investigations. So let's break down the most important rheumatological tests one by one with real clinical insight. Number one is RA factor or rheumatoid factor. So RA factor is an IgM antibody directed against the FC portion of IgG. Sounds complex? Just remember it's positive in about 70 to 80% of RA cases, but it's not specific. You may find RA factor positive in Sjogren's syndrome, SLE, TB, ILD, hepatitis C, and even aging. High titers may indicate extra-articular RA, but remember, a negative RA factor does not rule out rheumatoid arthritis. Always pair it with anti-CCP and other clinical signs or features. Now anti-CCP, it is anti-cyclic citrulated peptide. So now comes the precision test, anti-CCP. It's highly specific for RA, about 95 to 98% sensitivity. Also, anti-CCP appears early in disease and predicts more erosive and more aggressive course. If both RA factor and anti-CCP are positive, the diagnosis is almost certain. But if RA factor is positive and anti-CCP is negative, then think again. Now number 3 is ANA by IFA, that is indirect immunofluorescence. So ANA by IFA is a screening test for connective tissue diseases like SLE, MCTD, that is mixed connective tissue disease, and Sjogren's. A positive ANA test does not mean SLE automatically. It's positive in 30% of healthy people, especially in elderly women. What really matters is the pattern and the titer. So different patterns are like homogeneous pattern, it suggests SLE, speckled pattern in MCTD or Sjogren's, nuclear pattern in systemic sclerosis, centromere, limited scleroderma or CREST syndrome. Use these to guide further ANA profiling. Now, the fourth one is ANA blot or ANA profile. So ANA blot or profile tells you which specific nuclear antigen are targeted. So it helps subtype disease more precisely. So number one is anti-DS DNA, that is highly specific for SLE and correlate with the lupus nephritis. Anti-SM, that is specific but non-sensitive for SLE. Anti-RO-SSA and La SSB, that is seen in Sjogren's and neonatal lupus and congenital heart block. Anti-SCL70, diffuse systemic sclerosis. Anti-centromere, that is limited scleroderma. Anti-RNP strongly suggests MCTD. So each of these antibodies tells a different story. Read the full profile before labeling the disease.